Welcome to the recording of the webinar, Herpes zoster, shingles, why should we make the effort to prevent it, and how? The presenter is Dr. David Shasha and the webinar is hosted by Dr. Ferdinando Petrazzuoli. This webinar was recorded on the 20th of December 2022.
It's good evening again, ladies and gentlemen, dear colleagues, and welcome to this webinar on herpes zoster. The title is Herpes zoster, why should we make the effort to prevent it and how? It is a pleasure to have with us Dr. David Shasha, who is infectious specialist of infectious disease and internal medicine at Tel Aviv Medical Center in Tel Aviv, and the chief consultant of infectious disease of two Israeli HMOs. We also have the pleasure to have with us the president of Wonka Europe, Professor Shlomo Winker. Okay, David, the floor is yours.
Thank you very much, and thank you, Dr. Petrazzuoli and Professor Winker, and thank you, Wonka, for inviting me to give this talk. I'm very happy to give educational to family doctors. I'm mainly a hospital doctor, but I'm aware that most of the medical work is done in the community, so I'm always happy to share such educational with family doctors. So I'm going to share my screen just a second. Oh, where is that? Oh, here it is. So I hope you see my presentation. So
okay.
Yeah, do you see it? Thank you. So important infection that I guess most of you are quite familiar with. Zoster. I would touch know quite well. I'll talk about okay, sorry, something happened to my Zoom. Do you hear me now?
Yes, now it's much better. So try to link again.
Okay.
Yes, no, we can, yes, try to share your screen again.
Okay, do you see my screen now?
Yes.
Yes, perfect.
But not in presentation mode.
Okay, is it better now?
Yes.
Yes.
Okay, so I apologize. So I'm going to speak about the epidemiology of zoster and risk factors, the clinical manifestation. I would highlight the complications, and then I would speak about prevention of herpes zoster by the two available vaccine in market right now. There are two: the zoster live attenuated vaccine and the zoster recombinant vaccine. So as most of you familiar, zoster is a common infection, which is a reactivation of the VZV virus, varicella zoster virus. Most of us acquired VZV virus in childhood in a disease called chickenpox or varicella. This is a disseminated infection that causes fever and disseminated rash. Up till 15-20 years ago, 99.5% of the population got infected with varicella during childhood. Now it's less prevalent because of the vaccine to varicella. And 7 to 14 days after that infection, the virus actually enter a latent phase like all other herpes viruses. While we acquire them, they are with us for the rest of our life, and the virus enter a dormant or latent condition in the dorsal root ganglia in the spinal, near the spinal cord, and then the virus remains dormant or latent thanks to our immune system, mainly the cellular T-cell immune system. And the virus might reactivate later in life, either because in older age the immune system is getting weaker, or because of some immunodeficiencies that people might develop during life. And when that reactivation happens, the virus go in the sensory neurons, and this is the clinical presentation of zoster with rash that involves one dermatomes, a painful rash. So zoster, as I said, is quite a common diagnosis. Actually, 30% of the population would experience zoster during their lifetime. The incidence of zoster increasing with age. It is more common in female than in male, and more in white compared to black people. Interesting point is that the incidence of zoster is increasing during the last 3 decades. You can see it here in different age groups, that zoster incidence going up from the 90s until these days, and it actually increased by a factor of 2 to 3. We don't know exactly why that is happening. There are several possible explanations. One of the most important one is the varicella vaccination. As the youngest population is now routinely vaccinated against varicella, there is less varicella zoster virus in the environment, so we get less booster to our immune system. And when we see the virus less and getting less boosters, reactivation is more common. This explanation is probably only a partial explanation, because as you can see, the increase in the incidence of zoster actually happened since the mid-90s, while the varicella vaccination started only in 1996 and got better coverage only 10 years later. So probably there are other factors that contributing to increasing incidence of zoster. Important thing to say is that the varicella vaccination actually decreased dramatically the incidence of zoster among children. I already said that zoster is a disease of the older age, but still we might see zoster even among children, but children that were vaccinated to varicella has much smaller risk to develop zoster, as you can see here. So varicella vaccine was actually approved in 1996, but widespread coverage were reached only about 10 years later. And you can see here that from 2006, the incidence of zoster in different age group of children decreased by 70 to 80%. Still, we have at least 30 years until children that were first to get vaccinated to varicella would reach the age of 50, which is the major risk factor for developing zoster. So I guess that we won't see dramatic decrease in rates of zoster in the coming few decades. So what are the risk factors for developing zoster? The major risk factor is age, and you can see here in different countries that above the age of 50, the incidence of zoster is increasing very significantly. And we know that above the age of 85, 50% of the population would have at least one event of zoster. And the second risk factor for developing zoster is immunodeficiency. And you can see here different condition of immunodeficiency. I think that the most significant degree of immunodeficiency is actually bone marrow and stem cell transplantation. And in this group of patients, the incidence of zoster is 9 times greater than the general population. And it's also true that there is a much greater risk for zoster in solid organ transplantation in people living with HIV, especially those with CD4 below 200. But zoster is also more common in people living with HIV with normal CD4 and other iatrogenic states of immunodeficiency, either autoimmune disease that require treatment with immunosuppressive therapy, cancer, and other diagnoses. Clinical presentation of zoster, as you all know, is rash and neuritis. The rash can involve any dermatome, but usually it's a dermatomal rash of the thoracic or lumbal dermatomes. In 10%, zoster might appear in the face. Lesion lasts between 7 to 10 days. And at that point, when the lesion crossed, the patient is no longer infectious. This lesion might cause scarring, hypo, and hyperpigmentation. And the neuritis part of zoster is actually caused because of the involvement of the nerve ending and the ganglia, where you can see necrosis by pathology. And this is what the patient usually describe as burning or stabbing pain. The pain might be prolonged even 30 days after the rash started. And in 75% of patients, the pain actually precedes the rash. And this is something that might confuse us as a doctor, because some of the patient might be misdiagnosed as having angina or other infection or problems in their abdomen, like cholecystitis, appendicitis. It might mimic spinal disc herniation, renal colic, etc. I brought here several pictures that you all know, and I took them from up to date. As you can see here, this is a dermatomal rash of a thoracic dermatome, and here is a zoster involving the buttock. And I brought this picture to show you that usually the rash is a vesicular rash. It might start as a papular rash and then evolve to vesicular and pustular rash, and you can see the background of erythema. The diagnosis of zoster is usually clinical. We don't need, for most of the cases, any lab diagnosis. If we see painful vesicular rash in a dermatomal distribution, this is quite diagnostic for zoster. But there might be some atypical rashes in immunocompromised patients or those who are thrombocytopenic. The rash might be hemorrhagic, it might be disseminated, and then we might not be sure that this is zoster. And also sometimes the distribution of the rash is it might be confusing because it might involve the face or the genitals, and we might think that this might be a herpes simplex rash. And in those cases that we are not sure with the diagnosis, we can perform PCR, which is a rapid test to get results, and it's very sensitive and very much specific. So you might think that zoster is a mild disease of rash of several days and pain, but this is not true. Zoster is quite a bad diagnosis because it has complication. The most common complication of zoster is postherpetic neuralgia, which is pain that lasts more than 90 days after the rash starts. This is the most common complication of zoster. It appears in between 10 to 15% of those patients with zoster, but above the age of 80, it might reach prevalence of 20%. There are other very major and important neurological complications of zoster. Zoster might cause meningitis, meningoencephalitis, facial nerve palsy, or Ramsay-Hunt syndrome, where there is also involvement of the vestibulocochlear nerve. I said that zoster is a disease of the sensory nerve endings, but sometimes it might even involve motor neurons, and then you might see motor neuropathy. Zoster might cause myelitis, and it also has vascular complication like stroke, usually after the rash disappears. Zoster also might have complication in the eyes. The most common one and very significant is the herpes zoster ophthalmicus, which means that there is involvement of the ophthalmic division of the trigeminal nerve. And I brought here also a picture from up to date. You can see involvement. The rash is around the eye. It might involve the conjunctiva and later the cornea, including scarring and a risk for vision, and also involvement of the tip of the nose, which is a diagnostic of herpes zoster ophthalmicus. It might be, as I said, sight-threatening condition, and it's very important to diagnose it early and to start an antiviral treatment. Zoster might also cause catastrophic complication in the eye, which is acute retinal necrosis, usually in immunocompromised patient. And zoster might also be a recurrent disease. In 1 to 6% of patients, there might be more than one episode of zoster. But zoster might be dangerous, especially in immunocompromised patient, and the most dreadful complication of zoster is disseminated zoster, in which the rash is not confined to 1 or 2 dermatomes, but the virus is actually distributed by viremia and involves the whole body, and also visceral involvement, including pneumonitis, hepatitis, meningoencephalitis, and the mortality rates of disseminated zoster in immunocompromised zoster is very high. You should also know that all the other zoster complications, also those that I mentioned before, and recurrence are more common in immunocompromised patients. So now that we have understand the clinical presentation, risk factors, and mainly the complication of zoster, I'm going to talk about prevention of zoster now that we are convinced that this is a disease that we should actually make the effort to prevent. So we can prevent zoster by vaccines, and currently there are 2 approved zoster vaccine. And I would talk now about the first zoster vaccine, which is the live attenuated vaccine, or Zostavax. This vaccine is given once by a subcutaneous injection. It is a live virus in a very high dosage, 14 to 60 times the dosage of the virus in the varicella vaccine. And the efficacy of this vaccine was demonstrated in a very important and big study from 2006. That was a placebo-controlled randomized control trial that recruited about 40,000 adults over the age of 60. And these patients were randomized to receive either this zoster vaccine or placebo. And as you can see here, the primary endpoint of the study, there was 50% reduction in the incidence of zoster and a 67% reduction in the incidence of postherpetic neuralgia. And there was another randomized control trial looking at zoster live attenuated vaccine efficacy in younger age group of patients between 50 and 59 years. That was also a randomized control trial, quite big, with 22,000 participants, and the vaccine efficacy in that group was even better, 70%. There are a few problems or drawbacks of the live attenuated vaccine. First one is the durability of protection that was examined in this RCT with follow-up of up to 11 years, but also in other real-world study. What all of these studies show that there was quite a good protection up to 5 years post-vaccination, but significant lower protection from the 8 years onwards that actually reach no protection at all. For example, this cohort from North America, a cohort of almost 200,000 participants with much control. And as you can see here, the efficacy or effectiveness of the vaccine went down to about 40% till the 5th years, and after 8 years, almost no protection at all. Still, there was protection against postherpetic neuralgia even later in the later years of the studies. Another problem with the live attenuated vaccine that it is contraindicated in immunocompromised patient, and this is very important. This is a live-attenuated vaccine, very high dosage of the virus, and in people with immunodeficiency, that might cause the very dangerous complication of disseminated zoster. So we cannot give Zostavac to either patient with primary immunodeficiency, patient with hematological malignancy, hematopoietic stem cell and solid organ transplant, people living with HIV with CD4 below 200, and a patient receiving significant iatrogenic immunosuppression. On the other hand, this group of patients are the patients that with the highest need for zoster vaccination, because these are the patients with the highest risk to develop zoster, and if we cannot protect them with the zoster vaccine, this is a significant drawback of the vaccine. And that leads me to talk about the second zoster vaccine, Shingrix, which is a recombinant zoster vaccine. So there is no live virus in this vaccine. It's a recombinant vaccine, which is given in 2 doses, 2 to 6 months apart. You can shorten it to a minimum of 1 month between the 2 doses. And as I'll show you in a minute, this is a very potent and durable vaccine, and this was achieved due to 2 factors. First one is the selection of the antigen in the vaccine, and so the antigen in this vaccine is glycoprotein E, which is the membrane glycoprotein, which is the most abundant in the outer membrane of the virus. And the second part of engineering this vaccine was the adjuvant system that comprised of 2 very potent adjuvants, and all of these components are packed in a liposome structure. And this vaccine, as I said, is a non-virus live vaccine, but engineered recombinant vaccine. The efficacy of the Shingrix was examined in 2 very large randomized control trials that actually were conducted quite in parallel, one in the 70 and older age group, and the other one in a younger group of patients above the age of 50. So these are called the ZOE 15 and ZOE 70 and 50 studies. The primary endpoint was the prevention of zoster in the age group of this specific study. Patients were given either placebo or 2 doses of Shingrix. It was quite 2 large studies with total of more than 30,000 participants. And here you can see the efficacy result of the study. So you can see that in the different age group with follow-up of 3 years, the efficacy of the vaccine for preventing zoster was about 97%. In the age above 70, it was about 90% protection, which is a very impressive protection. And if we look here about the durability of protection up to 4 years, it remains quite high at 88% after the 4th years post-vaccination. The efficacy to prevent post-herpetic neuralgia was also very high, reaching almost 100% in the younger age group and about 90% in the age above 70. This vaccine is a very reactogenic vaccine, so you can see that both local and systemic side effects were quite common. So you can see either pain, redness, or swelling, but also systemic side effects like fatigue, fever, headache, and so on. And I'm sure that each of you that have patients that were vaccinated by Shingrix reported those side effects. Usually they are mild, and most of the patients come back to get the second dose of the vaccine. The durability of protection was examined in a follow-up study that was published earlier this year. And in a follow-up of up to 8 years of both of these ZOE 50 and 70 study, durability after 8 years remained very high, above around 84%. So can we compare these two vaccines, the zoster live and recombinant vaccine? So study of head-to-head was not conducted, but there are several indirect comparison, several network meta-analysis combining between 25 and 27 different studies, most of them real-world or observational studies, but also the registration studies. And what these meta-analysis showed is that the Shingrix, the recombinant vaccine, was superior in protection to Zostavax in patients about the age of 70. And I made this table for you to compare these two vaccines. So as you can see, in the younger age group, Zostavax gives 70% reduction in the risk of zoster in the age between 50 to 59, and for the Shingrix, in the age above 50, the protection was 96%. In the older age group, the age above 60, Zostavax gave protection of 50%, while in the age above 70, Shingrix gave protection above 89%. Durability of protection, as I said, waned significantly in the Zostavax vaccine, but was quite good of 84% protection after 8 years with the Shingrix. And systemic side effects were much common in the Shingrix vaccination. The Shingrix vaccine was also tested in patients with immunodeficiency. This is very important. As I said, these are the patients with the highest risk of developing zoster. So Shingrix was examined in autologous hematopoietic stem cell transplant in a randomized control trials of almost 2,000 participants, and show quite a nice reduction of risk of 68% protection in 2 years. Regarding the rest of groups of immunosuppression, either renal transplant, solid tumors, patients with hematological malignancy, and people living with HIV, it was tested for immunogenicity, so levels of antibody reaction, and also some cellular T-cell reaction, and showed quite nice immunogenicity. But in these groups, we don't have efficacy results for the protection. So now let's speak a little bit about the indication to vaccinate with the two of the zoster vaccines. So the zoster live attenuated vaccine was approved in 2006 in Europe. It is indicated for adults age 50 years and above, for the prevention of herpes zoster and postherpetic neuralgia, but it is contraindicated in immunocompromised individuals. And Shingrix was approved in Europe in 2018. It is indicated in adults above the age of 50, but also for adults above the age of 18 if they have increased risk for zoster, like patients with immunocompromised condition. Several common questions about these two vaccines. So zoster vaccine are recommended even for those who had zoster before. This is because, as I said before, there are several percent of the population that might have zoster a second time. If patient experience zoster and you want to vaccinate it, you should wait until the resolution of the rash completely before you vaccinate it. In the past, we even recommended to wait much longer. The Zostavax live attenuated vaccine, if you want to vaccinate someone who is about to start immunosuppression, you should give it at least 2 weeks before immunosuppression, or even better, 1 month before. As I said, this is a live attenuated virus, and you don't want to risk a patient with immunosuppression with disseminated zoster. And if patients receive immunosuppression, but this immunosuppression was stopped, you should better wait until at least 3 months before you give Zostavax. But it depends on which immunosuppression you are dealing with, because some of the immunosuppressive agent might act much longer, like anti-CD20 medication that can abolish humoral reaction for up to 1 year. Shingrix is given in 2 doses, 2 to 6 months apart, but if your patient is about to start immunosuppression, you can make this interval shorter to a minimum of 1 month. And if you want to vaccinate patients that receive already Zostavax with Shingrix, because as I showed, it is more potent and with a more durable protection, you should wait 2 months. Some information about availability and indication of this of Shingrix in several countries. So some of the countries approved and reimbursed it for the general population, older age. Some actually, in some it's indicated above the age of 50, and in younger adults with immunosuppression in a few countries. In the US, for example, you can no longer buy or prescribe Zostavax. You can only have Shingrix as the available zoster vaccine. So in summary, zoster is a common infection that might have significant complication, mainly in immunocompromised and older adults. The zoster live vaccine has several drawbacks. It is contraindicated in immunocompromised patients, and this is the main target population for vaccination. It is licensed for adults above the age of 50, and it's not licensed to young adults at risk. And it has significant waning immunity 5 years post-vaccination. Shingrix has a superior vaccine efficacy for the prevention of zoster and its complication. It has good durability of protection up to 8 years post-vaccination. It has a promising immunogenicity in immunocompromised, but it has more local and systemic side effects for those who are receiving it. So that's all what I wanted to cover in this talk, and I think that now it's the time for discussion. So I'm going to stop my screen sharing, and I give the stage back.
Thank you very much, Dr. Shasha. Yes, it was a very interesting presentation. You talked about 2 completely different vaccines. It seems that the indication of one is the contraindication for the other, so the other way around, so completely different. But we have already received some questions in the chat, maybe before you clearly showed what are the contraindications, maybe, but still you can respond to stress the point, what are the contraindication, especially for the new vaccine, the Shingrix, maybe only a few, if I understand.
Yeah, so I'm not sure it's right to say that one is actually covering the contraindication of the other. Zostavax is the older vaccine. It was a very good solution maybe 15 years ago when it was the only vaccine. But of course, it cannot be given to patients with immunocompromise, and those patients are at the highest risk for zoster. So for those patients in the countries when it is licensed and reimbursed, it's a very good solution. Contraindication for Shingrix, the recombinant vaccine, are mainly, I guess, hypersensitivity after getting the first dose. But beside that, patient with significant immunodeficiency still can get it. It's actually the ideal vaccine for them.
Okay, there is a question from Professor Jean-Pierre Jacquet. So people that are vaccinated between the age of 65 and 70 will have to receive another vaccination 5 years later. Is it too late, or is it?
I don't think it's too late. I show that the incidence of zoster increases with age, and even above the age of 80 and 85, it becomes very common. 50% of patients above the age of 85 would experience zoster, and it might be a disease with complications. So I don't see an upper limit of age to vaccinate people for zoster. Regarding those that receive Zostavax, it's true that I show that after 5 years, the degree of protection is very small. Still, there is no official recommendation of any Health Organization to give booster dose of Zostavax, so it's not something that is recommended, although it makes sense to give a kind of a better protection. I think that those that receive it, if it's available, I would vaccinate them with Shingrix, which is more protective and also give protection for a longer period.
Okay, there are two questions quite similar. So the first one is, will children who vaccinated for chickenpox need zona vaccine, so zoster vaccine, after 50 years when they are older? And the second question, quite similar, is, do vaccinated children have a bigger chance to get zoster before 50?
So what I showed is that vaccinated children to varicella have dramatically lower risk to develop zoster during childhood. So varicella vaccination started 1996 and more commonly after the year of 2006, 10. So these children are now 12. So we don't know what would be the future with those children and the risk at later stage, but still they can develop zoster, but in much lower frequency than unvaccinated children that acquired the wild type of varicella virus and not the vaccine virus. So this is regarding the second question. What was the first question?
The first question was, do vaccinated children have a bigger chance to get zoster before they? No, it seems that
this is what I said, that it's
lower.
not. Yeah, I think the first question was, should we vaccinate them against zoster? So just remember that zoster vaccine is actually approved and indicated above the age of 50, above the age of 18 only for those at risk, immunocompromised. So we don't vaccinate, and the vaccines are not even Shingrix licensed to be given below the age of 18. Regarding their future need for vaccination, I think we need more follow-up to learn about the incidence of zoster in those that were vaccinated with varicella during childhood.
I must say that I have a question myself, because it seems to me a bit strange that with the vaccine we have as a immunization for 5 years. But you also said that if a patient has got zoster, we can vaccinate him or her as soon as the let's say the cutaneous
The rash
disappear. Yeah. The rash, the cutaneous rash disappear. Why? It sounds strange.
I don't think it's a recommendation. I think this is the minimum time to vaccinate against zoster. You are completely right. In the past, we actually recommended to wait at least 1 year, because if you have zoster, I think the disease itself, it's a kind of booster that protects you against the second event of zoster. So it might make sense to wait at least 1 year. I might say that a lot of the population getting aware of the diagnosis of zoster after them or someone from their family is acquiring zoster, and then they understand that it's a bad disease and they want to get vaccinated. And then I get the question, I just had zoster, I want the vaccine as soon as possible. So it's possible to vaccinate as soon as the rash disappeared, but maybe it makes sense to wait a while, because the risk is lower during the first year after the event.
Ferdinando, pay attention that there are some questions also in chat, not only the questions. Okay.
Yes. There is this interesting question, because we have talked about vaccine, but there are also maybe people who got the disease. And so can you please refer to the prevention of complications by early stage in the disease threatened with acyclovir, and what is the recommended duration of treatment for older people with this the classical drug for this disease?
Yeah, of course, that if, sure. So if we diagnose a patient with a zoster, I show that this is a disease with a complication, and even without complication, it's not a pleasant rash, it's painful. So as soon as you make the diagnosis, of course, you should start treatment with either acyclovir or valacyclovir, high dose, and you treat for 7 to 10 days. It is decreasing the risk for complications, but sometimes, as I say, the rash even appears later after complications. So some patient might develop meningitis, and the rash comes only when the complication appears, and only then you can start treatment. But even if your patient, the only symptoms of zoster that he has is rash, of course, I would treat him with acyclovir or valacyclovir.
Thank you. There is another question from Dr. Miriam Verret. What is the optimal age to vaccinate? Given the waning of effect and the greater need for protection at older age, would it be better to wait for the age of 60 or 70 rather than vaccinated at 50?
So I think this question is much depend on the availability of the vaccine. The risk is quite substantial after the age of 50, and we see not small numbers of cases, even of people in their 30s and 40s. Still, the vaccine is approved from the age, I mean, both of them are approved for the general population from the age of 50, and I would recommend, if the vaccine is available, to vaccinate at that age. And when age is going older, the risk is bigger, so the recommendation to vaccinate is even stronger.
Maybe Shlomo, you have a question for Dr.
No. I think that the audience doesn't have any other questions. So I think it's time to finalize, or maybe another comment from you, Ferdinando, and the last comments from Dudi. I think that.
Okay, there is another question from the audience. Do you use steroids to prevent post-herpes neuralgia?
So actually, the way to cope with post-herpetic neuralgia is quite complicated. So treating early with acyclovir is an important part of the treatment, but after the patient developed the neuralgia, as I said, it's quite a late complication. You only diagnose it after the pain is prolonged for more than 3 months. Then, of course, antivirals are of no value, and then the main treatment is quite complicated, and it actually consists mainly of some analgesic. Not sure about treating with steroids.
Okay, may I, let's say, talk a little bit of my personal experience. I am a senior doctor of over 38 years of seniority in primary care. Yes, I can confirm my experience of this, that the disease now, the prevalence of the disease is much higher than in the past. And we have assisted, let's say, at a completely different epidemiological aspect of this disease. I can also confirm that I have started this new vaccine with only a few side effects among my patients, very, very few patients. Some patients have fever, but maybe less than 10%. And of course, nothing serious, nothing that that you can worry about. And so I don't have, of course, now any feedback for the long-term results, but in terms of side effects, because it seems that the new vaccine has more side effects than the older one, but frankly speaking, it seems that these side effects are very mild. So it's up to you now, Dr. Shasha, to give the final remarks on this for this webinar.
As I said, it's a very common diagnosis that I'm sure that every family physician is seeing from once in a while. It's important to diagnose it early and to start antivirals, to be aware of the complications, and also for the fact that the pain might come before the rash. So you should think about differential diagnosis of zoster when your patient has unexplained abdominal or some other parts of the body pain. And of course, to be aware of the two important vaccine, and especially the recombinant, very potent and good vaccine, and offer it to your patient to prevent the suffering and complication of this bad virus.
Okay.
Ferdinando, I want to say also something. Just
yes, please.
Finalizing. So first of all, I want to thank you both, Dr. Petrazzuoli and Dr. Shasha, for the very interesting lecture and the nice conversation between the two of you. And also, I would take the opportunity to wish you all Happy New Year and seasonal greetings. And I'm sure that this is the last lecture that you are going to hear before many of you are going to the end of the year and the New Year vacations. So thank you again, and Dr. Petrazzuoli, the stage is yours.
Thank you very much. I hope that you've enjoyed this webinar as much as I have. Good evening and bye-bye.
Bye-bye. Good night.